Hills, Michigan. So interesting case. This is a nice lady that comes to me from out of state with a history of her first implant in 1991 that was done according to the patient above the muscle. Then in 2009, she got saline implants according to the patient, and she was very firm and determined on that. That she got her second set of replacement in 2009, saline above the muscle. Now, when I examined her yesterday, looked at the rest of the paperwork, I told her you have silicone implants on exam, clearly. So she was very much distraught about that. So now she comes to me, she has had a contracture and a pain and firmness of the exam and unhappy with the many signs and symptoms of breast implant illness. Very nice lady from out of state. So as you will see, I removed the excess skin, and you can see how the implant like literally is if you will, flat. And again, this is on the right side. 100% total capsulectomy, 124/24 initials EB. And overall, as you can see, this was underneath the muscle. So underneath the muscle. So there's two problems. Number one already. Number one, the implant was below the muscle, and she said that it was above the muscle. And number two, this is a silicone implant just by touching it, and not a saline. Saline implants are like more a waterbed. If you touch it, you can see the vibrations that go back and forth. And so this is clearly a silicone implant done en bloc. I'm very happy and content with how the whole dissection has gone. Implants from 2009. So these are just 15 years old. So as I will go in, let's go ahead and dissect this open. Complete removal of the entire implant capsule done in the en bloc fashion. And so this is your, she said that she had 350 cc's. So everything contained. If I go in, you can see there's some fluid around. This is indeed, look at this fluid that's around. If I go in, and I go like this, look at this, what is this gel bleed phenomenon that we all know of? And this is that's leaching through. This is your Mentor 325, Mentor 325. And if you look at it, it's a little bit more on the yellow side, if you look. So it's kind of starting to break down, if you will. So again, as you will see, done en bloc. Let's go ahead and look at the inside. No abnormal fluid. Some areas relatively thick. Some areas relatively thin, and overall I'm very happy how, if I put the ruler here, you will see it is so thin that you can actually read the number 5, as you can see. No matter how thin, the entire capsule must be removed. And I was under the impression this is likely ruptured, but it is not. So again, good for her, and overall I'm very happy. Some areas relatively thick. Now overall, let's look at this. So this is, I saw this. Look at this suture material. So this suture is a proline suture right here. So interesting finding, proline suture. And as it sits right here, this is sitting right in the proximity of what is the implant. So imagine this is like a knife and this is cheese. And it's going to literally, you can imagine the trauma. So not a good idea. And this is what I would say a kind of generous amount of suture. You can see right here, look, it's poking through right here. And I'm going to go ahead and, so many surgeons like to use it in order to secure it so it doesn't move. And so all foreign body is removed. And look at this, this is relatively very hard. And I'm going to try to hold it like this, and I'll cut through so that I can see. Look at all of this. Very hard. Look, there's thick amounts of suture, and I'm going to go ahead and actually pull it out right here. See, this is your suture. I'm going to put it on a white background. Right here you can see suture, proline, relatively thick and embedded within and right in the proximity of the implant, which I don't like. And again over here too, you can see this reaction right next to it. Very hard. If I go in, look at all this scar tissue. All of this is scar tissue. You see the suture right here? Very hard. So the pathologist is going to look at it and silicone implant, not saline. So I'm going to go ahead and change my top glove, and I'm going to move over. Now the left side was very hard, very much in intensity. As you can see, done all nicely. But towards the very end, this was the area that was like literally super glued to the rib. And you can see like right here, this is actually part of cartilage. This is cartilage right here, cartilage. This was the rib, and you can see if I go in, as soon as this break in the capsule occurred, I was able to take a sponge and plug it in. And if you will, so let me go ahead and get, you can stay right here. This is the sponge that I use, and I was able to fan this out, spread this out, and I was able to literally plug this in. And then I continued to dissect all the way around. So as you can see, none of this spilled into the chest, right? And this was all contained, so it kind of works as like a plug or a seal. And I can tell by looking at this area, remember, the cartilage is right here. It is hard, as you will see right here. Actually, I will lift this up from where I dissected off of the rib right here. Now, some people, you can go ahead and focus on me. Some people say, well, why are you removing the cartilage? This ensures that I can remove it without the silicone spilling. Look, this is normal part of reconstruction. Someone needs to get their nose job. They actually harvest rib. They remove rib. The plastic surgeons remove rib from the chest, even on young 80-year-old kids, in order to reconstruct the nose. And they use this as a platform in order to rebuild, and basically use this as a rigid structure that's relatively pliable but not hard like bone. So just removing this cartilage here that is on top of that rib is ensuring that this is done in a fashion where all of the capsule is removed. And again, this is done in a very pristine way without any of the silicone spilling into the chest. So as I go in, let me go in. Actually, if you look at this hole, I cannot even pass my instrument through it. That's now I got it in. So I'm going to actually go in from here. You can see how thin it is, and clearly it is ruptured. And I'll tell you, this is my second case for the day, and none of this spilled into the chest, and none of this leaked out, and you can see it's completely disintegrated. This is supposed to be the safer gummy bear implant. I'll tell you, there's nothing safe about it, and you can see how it's ruptured. And I'm going to go ahead, before I touch it, let's look on the inside, and you can see all of this is contained. Here is your suture. Here's the, so less suture, but you can see it's sticking inside towards where the implant is, and it's kind of, as you can imagine, the back and forth movement is going to rub into the implant and hurt it. So overall, nothing out of the ordinary, but again, I want to show you. So if I go like this, it is so, let me use the ruler, this side. It is so thin, you can read number 1 right here. So no matter how thin the capsule, it has to be done in a pristine way, so none of this spills into the chest. This is like slime, and if you can imagine, if you get it once, it's going to be everywhere. And you know, we hear about this other case on social media, all of this, and I can read over here, this is your Mentor 325cc implant as well, completely disintegrated. Tell me anything, the gummy bear, you know, they show off and they say that the F-150 can go over it. You know, this is not safe, this is not healthy, and eventually the implants will rupture. In this case, 15 years, who knows, she might have been ruptured for some time. Sometimes, look, I did a case from 1979 a few weeks ago, maybe a month ago, and she was not ruptured on one side, and the other side she was ruptured. But the bottom line here is, look, this is your, obviously the gel bleed to a much lesser extent on the intact side, but certainly much more so on the left side. All contained, none of this spilled into the chest. She certainly got the silicone toxicity, silicone granulomas. Again, we will see what the pathology shows. Look at the color of this capsule. It does not look, I use the word healthy. The capsule has to go. That's the take-home message. If anyone says the capsule should be left behind, are you going to let this rupture into the chest? Absolutely not. So the gold standard is the end block. Even if it's not end block, which doesn't apply on the left side, it was 100% contained, 100% total capsulectomy without any of the silicone spilling into the chest. She's actually looking very good on table as far as how she recoiled, minus the inflammation that was severe, especially on the left side. She did not need drains like the many implants that I have removed that have been ruptured where the drain requirement was not there. She has good, healthy, viable tissue remaining behind. I've taken cultures for aerobic, anaerobic, and fungal. And as you will see, the implants will be returned to the patient. The capsules will be sent to pathology, rule out the BIA, ALCL, CD30 analysis, rule out lymphoma, rule out malignancy, rule out any abnormal pathology. She's got the twilight sedation with propofol, fentanyl, Versed, very comfortable. She will have no recollection, just like any of my patients, in a very safe, controlled, practical manner, such that she got the best surgery, which is complete containment of this badness, such that none of this spilled into the chest, and no need for drains, no need for lift. And the blood loss was literally, I would say, 5 cc's on one side, 5 cc's on the other, 10 cc's. This is vast majority of my patients, well over 99.5%, and I'm overall very happy and content with how the whole surgery went. This is what I say. Overall, the implants are not meant to be in the body forever. They will rupture, some sooner, some later. According to the Mentor guidelines, as you will see themselves, they say get an MRI at year 3, and then every 2 years they're onward. And the silent rupture cannot be detected by the physical exam. Certainly there can be some alerts to the patient because of the pain, the inflammation, the lymph nodes. She actually has some fullness on the left upper axilla area that she's going to get worked up once everything subsides, because this is certainly consistent with possible lymph nodes with the silicone in it that we know of from the many MRIs that have been done on many other patients. So we will see how she bounces back, minus these silicone implants, the left one being ruptured. And there you have it. This is Dr. Khan, Executive Plastic Surgery.